All right, so today we are going to talk about, the most common office procedures that you do. We're going to start by looking at your pre-procedure preparation and setup, go through some common office procedures, talk about post-procedure management, and then finally I'll do a live demonstration and I'll do some laceration repair, punch biopsy, excision of lesion, and of course show you instrument tying, hand tying, and anything else that comes up. If you have some specific questions for me, certainly I think we should have enough time for me to be able to address those as well. All right, so in terms of pre-procedure preparation and setup, the most important thing is to make sure that the patient and you are comfortable. There is nothing more awkward than attempting to do an excellent job at a procedure while you are completely uncomfortable, your back is aching, the angle is wrong, the light is poor. So take the time at the beginning of the procedure to set yourself up. So make sure that the patient is properly inclined or declined in a way that makes them comfortable. Little things like moving them towards the edge of the stretcher closest to you. Making sure that you take the time to, if you have a mobile procedure bed or stretcher, go ahead and angle it in the room, and that'll typically give you more space to have your procedure set up and also to have an assistant on the other side. Decide whether you're going to be sitting or standing. Sometimes it's advantageous for you to be sitting down, for example, if you're doing a hand laceration. So no matter what it is, take the time to figure out, are you going to be sitting or standing, and really take the time to position yourself and the patient so that you'll be comfortable. Go ahead and adjust your lights early on, and then anticipate as much as possible what you're going to do in the procedure. So take the time, see it in your mind's eye, think of all the steps of the procedure, and then go ahead and make sure that you have all of the supplies that you're going to need in order to accomplish that. Always, always, always grab at least one more suture than you think you need, because there's nothing more aggravating than then running around trying to find more suture or trying to find more local anesthetic or anything of that sort. It really slows you down. So always have extras. Usually when I set up my procedure field, I even set up down to my dressings all ready. They're ready to go. And then, of course, personal protective equipment, I don't need to tell you that. So wear your goggles and wear your mask and all that good stuff. Okay, so moving on to local anesthesia. All portions of a procedure should be preceded by local anesthetic. Anything less is uncivilized, and this is a complete gripe of mine, so bear with me. But, basically, it's not only is it cruel and unusual punishment to irrigate a laceration without local, but you just cannot do as effective of a job. So take the time to go ahead and numb the patient up, and that's going to allow you to do a much better job of making sure that the wound is well irrigated. You're going to either do a field block or a nerve block. So a field block, you're basically going to place local around the entire periphery of the wound or the area where you'll be operating. Or a nerve block, which can be advantageous in areas like the finger, some areas of the face, so that you don't distort the tissues as much. So particularly in the face, for example, if you're working on the lips, you may not want to do a field block because that's going to distort the tissue significantly. So I will go through some nerve blocks that might be useful for you a little bit later on in the presentation. Now, one of the most important things that I can talk to you about today and stress is the importance of being aware of toxicity of local anesthesia. I'm certain that you all are all aware of that, and there really is no excuse. It's an avoidable complication. And people have definitely run into trouble in their offices overdosing on local anesthesia. So as you know, the maximum doses for local are usually given in milligrams per milliliter, which is not very helpful because the anesthetics are usually given by a percentage. The concentration is usually given by percentage. So a quick and easy way to figure out what that percentage means in terms of milligrams to milliliter is by moving the decimal point one space to the right. So I will show you on our next slide here. So here are some of your most common local anesthetics, and let's use the top one, lidocaine 1% without epinephrine. So it's 1% lidocaine, so you're going to move the decimal place one to the right, which would make it a 10, which means there are 10 milligrams per milliliter in lidocaine. Now, in all honesty, there are lots of things that we don't understand about local anesthetics. And it's really much more complicated than this chart is demonstrating. So there are multiple important factors. It matters how dilute the local is, where you're applying it, over what degree of time you're applying it. So it's much more complicated than this. But nevertheless, this is sort of a good go-to for you for some of the main locals that you're going to be using. But I just wanted you to be aware that, you know, in the plastic surgery literature, for example, we are using up to 35 mg per kg of lidocaine, but in the very, very, very dilute form of tumescence. So point is, not so simple, but you really have to go by these maximum doses that have been given to us to make sure that you avoid having any problems, okay? So here are some of the most common things that I think that you'll be using in your office. We have lidocaine 1%, maximum dose 4. Some books are going to say 4 milligrams per kilogram. Some will say 5. So I put both of them here so that if you see it on a CME question, what have you, you know that they might be trying to get you to say 4 or they might be trying to get you to say 5. I usually keep 5 in my mind because it's just an easier number for me to remember. That means that for a 70 kilogram person, you're using 35 cc's. And typically it comes in those 20 cc bottles. So you're looking at being able to use a bottle and a half on your average adult. Time to onset, less than 2 minutes. And it's going to last about a half an hour to an hour or so. Now, as you add epinephrine to an anesthetic, you're going to have a longer duration of effectiveness. So lidocaine 1% with epinephrine, you're going to be able to use more because more of the local anesthetic is staying in a circumscribed area due to the vasoconstriction from the epinephrine. So we're looking at 7 milligrams per kilogram, which makes it about 50 cc's for a 70 kilo person. Again, the onset is about 2 minutes or so, but you're going to have a longer duration of effectiveness, so 2 to 6 hours in this case. Bupivacaine is a long-acting anesthetic. 0.25% is the typical one that you see, and this one's 2.5 mg per kg. So I basically remember that lidocaine is my short-acting, and I have 5 mg per kg, and bupivacaine is half of that, 2.5 milligrams per kilogram, 70 cc's for your average adult. Well, maybe not your average American adult, but nevertheless, 70 cc's. It's going to take about 5 minutes, though, for this to have effect because it's a longer lasting anesthetic, but it also takes longer to come on. So, but your effectiveness here is for about 2 to 4 hours. And then finally, bupivacaine with epinephrine. The books are going to give you, it gives us like a base, a circumscribed dose of 225 milligrams, and for a total volume of about 90 cc's for a 70 kilo adult. In my mind, I actually just still remember using the 2.5 mg per kg, which is more conservative, and it should certainly be safe, especially if you have epinephrine on board. Again, takes a little bit longer to come on in terms of effectiveness, but this is going to really last a really, really long time. 3 to 7 hours. Okay, now let's see. I'm just looking at one of these questions. So the question is about the summary of types of suture material that I prefer for different procedures, and we will definitely go through that as I'm going along with the different procedures. We will talk about that, Dr. Jansen. Okay. All right. So the most important thing that I really need you all to take home today is just about the toxicity of local anesthesia. And so Remember the early symptoms. Early symptoms, just think cranial nerve symptoms. So patients are going to complain about strange things like tingling around their mouth, paresthesias of their tongue. They're going to have ringing in their ears. They might have a metallic taste in their mouth. They might feel lightheaded. They might start to become drowsy. So those are sort of early warning signs that should kind of get your, attention and ring that bell in your mind. Now, once you start to really get in a point where you're having some trouble is obviously the late symptoms. And first, you're going to see CNS toxicity and then cardiac toxicity. So your CNS toxicity, you're going to see seizures, which can be addressed by applying or by giving a benzo. So something like Ativan can be given IM to help treat that. So CNS toxicity, either seizures or the patient may become obtended. And then cardiac toxicity is various types of dysrhythmias, and finally cardiac arrest. Now, what do you do if this happens? Well, this is not going to happen to you because you're going to remember your max doses, but basically the only thing to do in those situations is supportive care. So basically ACLS protocol, and you have to keep doing it until the local wears off. And it's really important to, I can't stress enough how important this is because there definitely have recently been in the news some reports of patients who died in the office because of overdoses on local. All right. Now, what things can you do to make it a little bit more pleasant for your patients when you're giving them local anesthetic? So first of all, consider giving a topical anesthetic cream. I'm sure that especially the pediatricians in the audience are well familiar with this. You can use something like Emla cream, place it underneath an occlusive dressing. Usually you need to put these on for at least 20 minutes and you get a sense that it's working because you'll see that the cream itself often gets absorbed into the skin. And so that'll give you an area of superficial anesthesia from which you can then give more complete local anesthesia using your liquid local. Mix a long-acting and a short-acting anesthetic, and this is what I typically do. That way, you've circumvented the problem with patients who kind of metabolize the short-acting local very quickly, because you have something sort of behind that is going to lengthen your time of successful, effective anesthesia. And then also it's nice because the patients leave your office and they still are pretty comfortable at the end of your case. And if you have to run out of the room or if you have an emergency, what have you, you still have a patient that is going to be relatively numb for some time and you're not going to have to sort of start all over again. Add sodium bicarbonate into your local. It's going to make it more pleasant for the patient. It also increases the effectiveness of the local, and the reason is that with the bicarb added, you have less of the local is in its ionized form, so you have more non-ionized, and those are able to enter the cells more easily, and therefore give you a more effective and longer acting anesthesia. My personal mix, in a 10 cc syringe, I use 50-50 of a long acting and a short acting. So typically I'll use lidocaine 1% with epinephrine, and I'll mix that with 4 cc's of 0.25% bupivacaine, and then I'll add, usually I'll add 2 cc's of sodium bicarb. Or you could do it as I put it on the slide, which is 4.5 plus 1 cc of sodium bicarb. But just having that little bit of bicarb in there definitely does make a difference in the comfort level of the patient. Infiltrate slowly. If you think about it, most of the trouble with pain that you have in the body has something to do with distension. So in appendicitis, you have a inflamed, dilated appendix. Colitis, same thing, dilated. Cholecystitis, same thing, inflamed, dilated. Dilatation causes pain, expansion causes pain. So the more slowly you expand, more slowly you expand the tissues, the less uncomfortable it's going to be for your patient. Be generous. Be generous, be generous. Just, you want to make sure that the patient is comfortable, and there's no reason to be stingy with the anesthetic. And I've given you your maximum doses. So, you know, for your regular adult, you have up to, you know, a bottle and a half of that 1% lidocaine that you can give. You really have a great deal of leeway. And then finally, be patient. I typically will give my local, and then I will go away and do other things. Why? Because I am impatient. So I give my local, and then I set up my procedure area, or I go and write my note during that time. I walk away, and I probably will leave patients at the very least somewhere between 10 to 15 minutes. For a nerve block, I'll sometimes leave them about 20 minutes. And if you're using a combination of long-acting and short-acting local, you know that you're going to achieve, you're still going to have anesthesia by the time you come back. Now, Dr. Watson asked why the combination of long and short-acting administered at once. And like I said, what I like to do is have something that is going to last for a longer amount of time. So the short-acting is going to come on quickly. Okay, so that's going to get the patient ready for the procedure quickly. But then you have the longer acting one that's going to be present in the background, but the onset of that takes a little bit longer. But I very much like that combination, especially when you run into a procedure that takes you longer than anticipated, or when you find yourself having another emergency and having to step out of the room. Being gone for 10 to 15 minutes using just regular lidocaine 1% might put you in a situation where by the time you return to the patient, they no longer are anesthetized. And I try to avoid having to give them local multiple times. So I try to do it at one fell swoop, which is why I use the 50-50 of long-acting and short-acting together. Now, when I'm giving local, what I like to do is give it in the deep tissues first and then come superficially. And let me tell you why. So I try to give the local at a deep dermal or sub-Q level and then come into the dermis or almost epidermal after that. So if you look at this image here, so here we have the epidermis. This is the dermis, and this is subcutaneous tissue, and these are the nerves running through. And I think of this sort of like a tree trunks and then branches type of setup. So if you give your local deep first, you're at the level of the tree trunks, which is less painful. You don't have as large of a surface area. The nerves have not branched out and arborized so much, which is more painful. So I like to give it a little bit deeper first in the deep dermis or just very superficially in the sub-Q. And then I come more superficially. And that's the point where you can sort of appreciate that classic wheel that we're looking for often when we're giving local. And I'll demonstrate even just how I like to give local towards the end in the live demonstration. But I hope that this gives you a sense of why I like to use that technique. The one thing to remember, though, is that you do have to administer it in both places. Because if you only give local at the level of the tree trunks, it's hard to anticipate where those branches are coming from. As you see in this picture, you know, the branches may actually be coming from another trunk, and you may not have gotten that area. So you do have to hit both levels. But I find that if you go deeper first, it somehow seems to help the patients a little bit. Okay, so now looking at some specific blocks that you can do. So finger block, this is key. It seems like, you know, there are some of you who are doing some types of hand lacerations in your offices. And so your fingers, you have the level of your common digital nerve, which I don't know if you can really appreciate it in this image. It's kind of small. But here, at the level of about your MCP joints, you're going to have your common digital nerve, and then that's going to split up into a digital nerve that's going to run along each side of each finger. And so you're going to want to do your finger block either on each side of the finger, or you can do it at the level of the MCP joint. And I'm going to show you that in the next slide. Here in that second picture, you can appreciate that your nerve is lying fairly close to, the level of the tendon and the bone, which are, here's the bone, here's the tendon. So you're going fairly deep in order to get there. So here you have a finger block. You can do a dorsal approach or you can do a volar approach. I prefer a dorsal approach, and the reason is, that if you think about it, there are less nerve endings on the dorsum as opposed to the palm of your hand. So I prefer a dorsal approach. So I will typically come in at an angle of 45 degrees or so. Going in, I'm heading towards the bone. I would estimate that I'm probably putting my needle in maybe about a centimeter or so in terms of depth. And then you're going to infiltrate about 2 to 3 cc's on each side, and enough that you can start to see the tissues distend. Be generous, okay? Alternatively, you can do the same via volar approach. You can approach from either side, each digital nerve, or alternatively, you can go right at the level of the MCP joint. And like I showed you in the previous anatomical image of the hand, this would be the level of the common digital nerve, so you would potentially be able to get the patient blocked with just one stick right there, okay, at about the level of the MCP joint. And again, 2 to 3 cc's. Dr. White asked me about using epinephrine on the finger and the toes, and yes, you can. It is old school thinking, but guess what? Almost every single textbook still says not to use epinephrine on the fingers, and it's just simply not true. I use it all the time, definitely on fingers, definitely on toes. I haven't done any penile laceration repairs, but I'm told it's fine on the penis as well. My only caution would be the time to reconsider using epinephrine is if you're worried about whether or not the finger is viable. So if the vascularization is in question, then I wouldn't use epinephrine. But my guess is if you're really questioning the vascularization, you're probably referring that patient out to an emergency setting. So let's go through a few facial nerve blocks. So I'll go through 3 of them, which are a supraorbital nerve block, an infraorbital nerve block, and a mental nerve block. And all of the facial nerves are going to run at the level of your mid-pupillary line. So that's about 2.5 centimeters from the midline. So mid-pupillary line, they're all in a straight line. And they're going to give you anesthesia to various parts of the face. So let me go through those. So I have this skull here. I think some of the foramina are a little bit difficult to see. But anyway, the first one is the supraorbital nerve. So you're going to palpate the supraorbital rim, which is here. And you can, I encourage you to palpate on your own self right now while you are at home or office or wherever you are. So palpate along the supraorbital rim, and you're going to find that you're going to feel a little notch, okay? Supraorbital rim, you're going to feel a little notch, again, at about the mid-pupillary line, and that's your supraorbital nerve. Supraorbital nerve block is going to be great for any forehead lacerations and stuff that you're going to be doing, okay? So you're going to basically transcutaneously aim for that foramen, and you're going to apply about 2 to 3 cc's of local to that area, and you're just going to see it and feel it distend over that area of the supraorbital nerve. Okay. In terms of the infraorbital nerve, again, same concept, so mid-pupillary line. You're going to palpate the foramen. It's going to be about a centimeter below the infraorbital rim. And again, you're going mid-pupillary line, and you're going to feel a depression. So I encourage you again, go ahead and feel on yourself. So infraorbital rim, come a little bit below that, come to your mid-pupillary line. You're going to feel a little divot there. So here on our skeleton here is, you can see the infraorbital foramen right there. And again, you're going to inject 1 to 2 cc's in that area transcutaneously. Now you can also give local to that area transorally. So you're going to open the lip and you're going to go at about the level of the second premolar. So you have your canine. I don't know if yeah, his canine is not very well defined, but most of us know what the canine looks like. So you're going to canine, and then you're going 2 teeth beyond the canine, going outward, okay, going towards the back of the mouth. So those are your premolars. Your second premolar, you're going to be palpating with one finger where the infraorbital foramen is, and then you can just go, right through the gum with your syringe heading towards the infraorbital foramen and deposit 1 to 2 cc's of fluid there. And you can palpate with your other finger, and again, just feel that distension underneath your finger. The mental nerve block, so same thing, mid-pupillary line. These all line up. You can go transcutaneously. So you're thinking about where the gum line is. You're going a centimeter below the gum line at about the level of the second premolar. Again, I want you to palpate on yourself, and you're going to feel a divot. And you can go through the skin, deposit 1 to 2 cc's there, or you can go transorally. Again, you're looking at the second premolar. Try to palpate the foramen at the same time and inject 1 to 2 cc's. And then you can do it a transoral approach. The benefit of the transoral approaches, I would say, are mostly because they're less painful for the patient. The sensation to the gums is not quite the same, and is not as specific and as intense as it is transcutaneously. But of course, if you're going to be injecting in the mouth, you just need to be aware of, switching your syringes back and forth from skin to mouth and what have you, okay? I do not suggest, one question from Dr. Esplin is whether you can use EMLA for the mucosa. I do not suggest doing that. The EMLA formulations are usually for your regular transcutaneous, not for mucosal surfaces. Intraorally, there are, of course, sort of like your hurricane sprays and stuff that you can use. Of course, there's some issues with those, like methemoglobinemia and what have you. The thing is, too, that if you had to use something, I would probably go for something more like Eurojet, and then you could, wipe it out or suck it out. But most of those things are not really made to be ingested orally. Okay, and no problem, Dr. Cruz. I'm happy to give that to you. I'm happy to provide a copy of my presentation to anyone who would like it. Okay, irrigation. This is definitely my pet peeve. I think that irrigating the patient out is probably the most important thing that you can do for them at all. And quite frankly, if you irrigated a patient well and then you didn't even close their laceration, you've probably done them a huge service. So this is the most important thing in any laceration repair. And that's probably why I always stress the importance of actually going ahead and anesthetize the patient before you irrigate them, because it'll just allow you to be way more thorough, okay? So be thorough about irrigation, open the wound, explore it, get in there. Both pressure and volume of irrigation are going to significantly decrease your bacterial burden. And so it's important to try to achieve both of those. My most important thing that I try to do is to achieve this in the quickest, most efficient manner that I possibly can, because I think that the reason why most of us don't do a good job irrigating is that it takes too darn long. I get bored. It's just a nightmare. So here are some suggestions for me. Okay, this is sort of the old school method. You know, you're going in here with the syringe and, you know, you're going back and forth. It's going to take forever. These little, you know, covers are quite handy. They're good. The splash guards, it protects you, but also I find that it does help with the, that plus a syringe is going to give you more pressure on your irrigation, which is a good thing. Okay, so you could definitely go this route, but it takes too long. It takes way too long for me. I get bored. So what I prefer to do is some of our EDs have this handy dandy cover here that you can just simply screw on to any size of saline bottle. And all you do is, you know, undo the cover, you screw that on, and instantly you have a high pressure method of irrigation, super easy, very quick. I can get through this, you know, 250 cc bottle very, very quickly. You know, so it's a no-brainer for me to quickly irrigate somebody with 250, 500 cc's, what have you. If it's a very contaminated, a large wound, then I start to do things like I will set up IV tubing to a normal saline 1 liter bag, and I'll use a pressure bag, like the arterial pressure bag, and I'll use that to irrigate. The whole concept is get a large volume in there with some good amount of pressure, but do it quickly so that you don't get bored with irrigating. Okay, now if you don't have this handy dandy, you know, cool splash thing, you can kind of do the MacGyver route, which is what I'm usually doing when I'm in the emergency room. So I have the cap, and I'm usually carefully using a number 11 blade, and I will just make sure you do it at an angle, and I will just, you know, keep twirling the bottle, angling until I core out a little hole in the top. I find this easier to do than, I'm not going to keep doing this, but you'll just basically core out a hole in the middle. But I find that easier to do than trying to push a large bore needle in there, because the plastic is so thick. So I would carefully suggest that you use an 11 blade and just angle it. If you angle it and you just twirl the bottle, you'll find that you'll very quickly core through there, okay? All right. Okay, can you zoom me back in? Colin? Thank you. All right. So irrigate, 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 okay? All right. I don't have anything brilliant to say about prepping and draping, except for the fact that do it widely. Give yourself lots of room. Anytime that I'm doing a facial laceration, I typically will prep the entire face. This way that you don't have a patient who is claustrophobic, who is, you know, having a meltdown in the middle of your laceration repair. You're able to see your field easily. You're able to compare one side to the other. So you'll notice if the eyebrow that you're fixing is now, you know, 2 centimeters higher than the other side. And you don't lose your sterile field so easily. So prep widely. I think that that's, you know, a key thing. And that's in any area, in extremities. If I have hand lacerations, I often will prep the entire hand. That way you're easily able to get the patient to flip their hand back and forth and reposition them, what have you, without losing your sterile field. Okay, so prep widely, and you can use betadine, ChloraPrep, whatever. So common office procedures, we're going to go quickly through each of these four: laceration repair, incision and drainage, and then punch biopsy, and then excision of a lesion. So laceration repair, we've gone through some of these concepts already: irrigate, explore, evaluate. Okay, make sure you really take your time, irrigate that wound out well. And I think that you'll find that if you look at the shape of the edges of the wound, you're usually able to appreciate how those edges might fit together. And I think that if you take time to look at that and just see sort of how the jigsaw puzzle fits together, between that and irrigating well, you'll really notice that there's oftentimes no tissue missing. We get a lot of referrals that are talking about, there's a lot of tissue missing, what have you. Oftentimes it's not missing, just tissues tend to fall, apart and gape widely once they get deeper. But it really is, less common for me to discover that there's actually tissue missing. Try to limit the amount of debridement that you do. Really limit it to devitalized tissues only. Remember that a jagged edge is actually going to be less visible or attractive to the eye than a straight edge. So I think that some people feel the need that they want to trim the edges to straighten them up. Try to resist that temptation, because you're actually making it more visible to the eye. In plastic surgery, we often use something that's called a Z-plasty, and we make an incision that's in the shape of a Z and move tissues, and that actually makes scars less obvious to the eye. So try to minimize the debridement. Of course, if something is frankly necrotic, devitalized, yes, take it off. Especially in the face, be judicious about debridement, because you'd be surprised. Most things in the face actually do recover fine. Typically, you're going to be using simple interrupted sutures. Occasionally, you're going to use horizontal mattress sutures. That's typically in areas where you have more tension. That's good in the palm of the hand for hand lacerations. And again, I'll talk about this a little bit more as we go through the various types of laceration repair. Basic suture material. What do you need in your office? You need, from my perspective, with these 3 sutures and staples, shh, don't tell my plastic surgery colleagues and I'm telling you this, but with these 3 sutures and some staples, you can probably accomplish most of the repairs that you're going to do in your office. And there's also a place for tissue adhesives as well. But you want a nylon suture, okay? You want plain gut. So if you had to choose between chromic gut and plain gut, I would choose plain gut. But if you could do both, it is advantageous to have both. And then finally, a monocryl suture. All of the sutures that I've shown you are monofilament sutures, and the monocryl is for your deep dermals, and this is a suture that is going to dissolve, okay, as is the plain gut. And then the nylon is going to be a suture that's going to have to be removed, okay? And pretty much with these 3, I think that you are fine in your office for almost anything that you would need to do. All right, so let's go back here. All right. And staples, I just want you to note that staples are an excellent option for scalp lacerations. So with a scalp laceration, all you're trying to do is, if the galea is interrupted, you want to put a couple of deep stitches in there so that you get the galea back continuous. But apart from that, this is a non-cosmetic area. Staples are fine, okay? All right, facial lacerations. So now we're getting into a little bit more of the detail. I think that Dr. Jansen wanted to talk a little bit about this. So for facial lacerations, usually I do a 2-layer repair. You want to start by placing a few deep dermal sutures, and that would be using the monocryl. So a few deep dermal sutures, to achieve a tension-free approximation of the wound edges. You're not doing a lot of these stitches. They're just a few key stitches in order to get things in place, okay? So I would be surprised if I were to place deep dermals more often than every 7 millimeters or so. And it really depends on the kind of wound. There's some wounds that you put 1 or 2 deep dermals and it just puts the tissues back together. So I don't want to give you a strict number in terms of distance that the deep dermal should be together. It's really just enough to get those tissues to start kissing, okay? And then you are going to superficially use a nylon or a plain gut suture. Now, the 5/0 nylon or 6/0 nylon, adults. In children, choose the plain gut. Why? Because you don't want to have to take the sutures out, okay? And plain gut will go away quickly enough that it shouldn't leave railroad tracks. You want to try to avoid the chromic gut because the chromic gut will cause even more inflammation than the plain gut does. So I would go for plain gut in children. For things like dog bites, irrigate them very, very, very aggressively and then close them accurately. You don't have to do it super tight like you would do other facial lacerations, but if you irrigate them out very, very well, I think that it's usually worth your while to close them accurately. And of course, these are patients that you want to send home on antibiotics, typically augmentin, and they would be a patient who you'd want to have close follow-up just in terms of making sure they're not getting infected. Now, a little tip for repairing the lip, for example, always, always, always reapproximate the muscle. Now, the reason is that sometimes I'll see patients come in who've had laceration repairs, and you can tell that their muscle wasn't repaired because when they smile, one side of their lip goes this way and the other side goes the other way. And the reason for that is that the orbicularis muscle is a circle and it's a sphincter. And so if you don't repair it, one part of it is going to animate in one direction and the other one's going to animate in the opposite direction. So always reapproximate the muscle in the lip. And then the other thing is, if you do face the challenge of a laceration that just crosses the vermilion border, try to avoid trying to place a stitch right at the vermilion border. Try to put a stitch right above it and right below it, and it'll actually help you a little better to match things up. And so that's what I would do in terms of the vermilion border. If you have human bites are just as disgusting or even worse than animal bites. Same concept. Wash it out, wash it out, wash it out, wash it out, and then close it. Cat bites are a little bit different, and you'll typically encounter the cat bites more so in the hand than in the face. And the cat bites are worse because they're kind of puncture marks and they inoculate things more deeply. A cat bite in the face, it's probably such a small enough puncture mark that I would consider maybe leaving it open if you don't feel confident that you've irrigated it aggressively, because they're typically small enough and it's okay to let them heal in, but they're more likely to get infected because the inoculation goes in deep because the teeth are sharp and long. So here's an example of a facial laceration. So we have one on the upper lip. The lower lip is involving an intraoral laceration involving the gums here. And so the approach here is just simply, a few deep dermal stitches in order to reapproximate those wound edges. With the intraoral laceration, what I did was go from, typically I'll end up going from the inside out. So I'll close the mucosa first, then put a stitch in the muscle, and then close the skin superficially. Intraorally, I'll show you this patient's post-op. So here you see my closure. I don't know if you can appreciate intraorally that the stitches are white, and those are actually vicryl stitches. And I know I already told you that the must-haves for your office, you don't need to have vicryl stitches, but I just wanted to throw that out there, that that's a good option if you think the intraoral laceration is severe enough that it might not heal quickly enough to use chromic gut. So sometimes I'll use vicryl because it lasts a little bit longer and it'll give a better chance for that that wound to heal. If you're going to be doing a lot of intraoral lacerations, then I would advise you to add chromic gut to your selection of sutures that you keep at your office. And here's this gentleman's post-operative. Came out pretty well. All right, hand lacerations. So first things first, do a good hand examination. Check for vascular supply, make sure that their sensation's intact, make sure they have good flexion and extension. Now, most of these lacerations, even including those with tendon injury, do not need to be immediately referred in an emergent setting. These can be outpatient issues that you can refer them out to a hand surgeon. And plastic surgeons do hand surgery. We started hand surgery, so don't forget about us. But do simple interrupted sutures. And the sutures that you're going to be using are typically going to be 3/0 or 4/0 nylon or chromic sutures. And again, I chose the chromic for children, so you don't have to take those stitches out. Or of course, if you have any patients who you're not sure if they're going to come back for the suture removal, chromic gut would be a good option for them. A tip is that when you are doing laceration repairs in the palm, try using horizontal mattress sutures, which will give you a better eversion of your palmar wounds, okay? So here's this patient after his repair. Extremity lacerations. So usually you're doing a single layer closure here. There's no need to put deep dermals in, and you're just incorporating subcutaneous tissues and skin at the same time, okay? Use simple interrupted sutures. Why? Because you want to give enough room for drainage. The types of suture, 2/0, usually I'm using 3/0 nylon, or again, chromic sutures for someone who you don't want to remove the sutures with. Avoid closing these excessively tightly. Why? Because the extremities, the lower extremities in particular, usually tends to have some problems with ischemia. So don't close it too tightly, and also doing interrupted sutures and not closed too tightly is going to allow for it to drain. If you have something that is very contaminated, you can consider putting a little Penrose drain in there just to allow for drainage, or just simply to leave a little portion of the wound open and let it drain out, better than getting an infection. Now, tissue adhesives. You can use Dermabond. You can use Dermabond, but let me tell you which lacerations these are best for. Linear lacerations. So you don't want anything with too many jagged edges because it's just too difficult to get well approximated. Small. So you only want it, I really limit it to 2 to 3 centimeters. The reason is that, you know, you're kind of relying on the surrounding tissues to keep things stable. And so a very long laceration just doesn't allow you to have that much stability around the wound. So you don't want to be closing something that's 6 or 7 centimeters using Dermabond. Use it on injuries that are epidermal or very superficial dermal, and wounds that have well approximated edges. When shouldn't you use it? Deep dermal injuries, irregular or uneven edges, wounds that have significant tension or are crossing joints, or wounds that are involving moisture mucosal surfaces. Dr. Richter asked about what is eversion of palmar sutures. So I'm talking about doing sutures in the palm, and in the palm you really want, that skin is very, very tough. And so you really want to have those edges piled up. So this is, you know, this is flat. Everted kind of gives you this, you know, sense of the tissues being, more of the dermis being in contact in an everted suture. And doing a horizontal mattress allows for that to happen more easily. And I will show you a horizontal mattress in a few minutes. So I&D, Okay, nobody, no patient is ever going to be happy with you when you are doing an IND. They're just not. They're going to be painful. I just am honest with the patient that I'm not going to be able to get this perfectly anesthetized for them. I do a field block, and I try to plan my incision ahead of time, thinking about the relaxed skin tension line. So think about where do the normal wrinkles and creases happen in that area, and try to orient your incision that way. So in the face, go along with how the relaxed skin tension lines go, and then you're not going to have as conspicuous of a scar. Always make the incision larger than you think. I don't think that I've ever encountered an IND that was too big, but I often encounter unsuccessful INDs because they're too small, and the wound basically ends up closing up again and the infection reoccurs, okay? So make it larger than you think you should. Use a number 11 blade because it allows good control and gives you a sawing kind of motion, and I'll show you that shortly. And then go ahead and spread bluntly in the area to break up any loculations, because sometimes there can be little pockets. Irrigate, 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 which is my fanaticism, and then pack it with a little packing to keep it open, okay? Finally, the punch biopsy, we're looking at 3, 4, or 5 millimeter circular punch. You're just gonna use a twisting motion between your fingers until the hub of the trephine meets the tissue. You're pulling it out. Sometimes when you then pull out the tissue, you might have to snip it at the base a little bit just in order to get it out. You're going to close these with simple interrupted sutures, 4/0 nylon. These are going to even right out. You don't need to extend the incision. You don't need to do anything. Just close them. Typically, even with a 5 millimeter punch, I think the most I've ever put in is 3 stitches, usually 2. When you're doing a lesion, so first thing you're going to do is you're going to measure out and mark any needed margin. So for example, if it was something like you thought it was a basal cell, you'd be marking a 5 millimeter margin around it. Otherwise, just mark around the lesion and then sit back and think about the direction of your incision that you're going to plan. So in order to do this, look at the relaxed skin tension lines. Where do they fall? So you can appreciate that in this image here. Just looking at, where the natural wrinkles are in the face, and then planning your incision accordingly. And then just push on the tissues in different directions and just see, hey, what comes together, and use those 2 pieces of information to plan your excision. Your excision is going to be a lenticular excision, which is what we're showing here in this image. It's a lenticular shape, and it's typically a length to width ratio of 3:1 to avoid having dog ears at the end. It is okay to use either new gauze or iodoform packing after an incision and drainage. This was a question, sorry, from Dr. White. It does not matter. It doesn't make a difference either way. It's definitely the act of you draining it and keeping that incision open enough for continued drainage. So it doesn't really matter. You can just use gauze if you want. All right, a tip. When you are doing lesions, all of us have a tendency to angle in with our blade. I encourage you to try tipping your blade slightly outside. Tip it slightly outward when you're doing your lesion excision. The reason is that, and I hope you can appreciate this, that this might be true from this image that I show you. But if you tip your blade slightly out, you're going to be encouraging the dermis. When you put it together, you're going to encourage that dermis because of the angle, you're going to get more eversion when you put that together than if you were to angle it the other way, okay? So it doesn't have to be that severe, but try angling out slightly, and you might find that your wounds actually come together a little bit better and look a little bit better. All right, post-procedure management, we'll go through this quickly because I definitely want to give some time for some demo and give you guys some chance for some more questions. So for the face, early post-procedure, vasopressin, I usually say 3 times daily and as needed. It's more like lip gloss rather than toothpaste. And about 5 days. The reason I say 5 days is that a lot of people develop a dermatitis to bacitracin or neosporin. So I want to eliminate that confusion that they're getting an infection. So I usually say 5 days, and then they move on to some kind of other emollient. You can also do steri strips if you think that there's a patient who's going to be fiddling with the area, or if the wound is too oozy, let me take that back. You don't want to use steri strips if a wound is too oozy. But if you think they're going to fiddle with the wound and just to give extra support to the wound, definitely steri strips are within reason. Wound can get wet after 48 hours, and remove the sutures in 5 to 7 days to avoid railroad tracks. Late post-procedure, everybody should be using sunscreen anyway, but reiterate that to your patients. And about 3 weeks out, they can start massaging to soften that scar. And it doesn't matter what they use, vitamin E, Mederma, lotion, does not matter. For hand injuries, put some Xeroform on there. If you think it's going to be very sticky and very painful, add some bacitracin to the Xeroform. Put any type of soft dressing on there, whether it's Curlex or gauze or what have you. And then it's very important to immobilize. I would err on the side of immobilizing more than less, because sometimes we have the patients come in with the finger splint and it's barely on and it's not doing anything. Most people can be in a resting hand splint easily for a couple of weeks without having a problem. So I would rather put them in a resting hand splint, and it's in position of safety, so you want 90 degrees at the MCP joint and about 25 to 30 degrees at the wrist. Suture should come out in 10 to 14 days. For the lower extremity, again, Xeroform, soft dressing, consider an ACE wrap just to help with edema. Again, consider immobilization in wounds that you think are tenuous or patients that you think might be a little non-adherent. So put them in a knee immobilizer if it's a really bad laceration over the knee, or an air cast. Consider crutches for a short amount of time. Tell them to elevate the extremity, very important to help with the edema and with the healing. And take those sutures out in 2 weeks to 4 weeks even, we do for areas that we're concerned about. And then for the IND, post-procedure, tell them that they can get in the shower, let the packing get wet, and take the packing out in the shower. It's much more comfortable for patients, especially with the facial INDs. That's what I do. And then they should be repacking the wound once daily. So let's show you a few things. All right, so hopefully you can see okay. I can definitely try to make some adjustments if you're having a tough time seeing things, so let me know. Okay, so let's start with some real simple stuff, which will be quick. So let's start by doing the punch biopsy, okay? So here we are. Here is your punch. This is a 3 millimeter punch. You can see you have the little, this is your knife part, your trephine. You're just going in. You're just using a twisting motion, okay? You're going to go down to the hub of the trephine. I don't know if I'll be successful here on the pig's foot is not that thick, okay? But I went down to the hub. All right, so hopefully you can appreciate a little hole there. You're just pulling it out. Use a little scissor to snip the base of it so that you get the full portion of your excision. And that's about it. Okay. Then you're going to close that laceration up.
Is there any rule about how wide you should go when it comes to a lesion? Like, should you be a millimeter, a larger, 2 millimeters?
I think that if you are taking out something that's a benign lesion, you can pretty much just hug the lesion. You definitely don't need more than a millimeter. If you are taking out a lesion that's more questionable, like for example, if you really do suspect that it's basal cell or squamous cell, you should be using a 5 millimeter margin there, okay? And then I'll just whip this closed really quickly. We'll do some more in terms of laceration repair, but I'm just closing this. The suture I'm using for the demo is a silk suture, and the only reason I'm doing that is because it was the only one that I had that was large enough so that you guys could really see what I'm doing. Don't worry, I'm going to show you in better detail about how to do the instrument tie and close that. Okay, so that was the punch biopsy. Let's look at just quickly what you want to be thinking about in terms of an incision and drainage. So this is your number 11 blade. I recommend using the number 11 blade if you are going to be doing an IND. Of course, you can use a 15. I have a 15 here, and you can use a number 10. Those are all fine. I prefer the 11 though, because you can really control and you can have a nice sawing type of motion. So, you know, if I were to decide that this was the area that I wanted to do my IND, and I would have done my field block already. So let's actually start with that, because I did say that I was going to show you how I like to do my local anesthesia. So I usually will use a TB syringe, okay? This is when I'm feeling really, really nice. But TB syringe, it's a teeny tiny, you know, little syringe, so it's not going to really, most patients won't, this shouldn't hurt them too much. So I'm gonna raise a little wheel, okay? And just, you know, right below the epidermis. You're not going too deep here. And at least it numbs them up a little bit so that they can tolerate the needle that's going to come afterward. So I raise my little wheel, and then when I'm giving the local, I try to plan ahead of time and think to myself, how can I avoid sticking this patient multiple times? So I try to think about, you know, how am I going to approach this so that I minimize the number of times that I'm going to have to stick them with the needle. So let's just make a little injury here. So in this case, I would give that little tuberculin needle on both ends. Raise a little wheel on both ends. And then I would plan to come in from either side. So I'd go in. Again, like I said, I prefer to give a deeper level first, so deep dermal and deep or deep subcutaneous. Then I go in more superficially. Probably difficult for you guys to see there, but maybe you're starting to see it now really puff up. So at that, there I'm in a deep, a superficial dermal or almost epidermal level. And then if you notice that I barely even came out, and I just switched to the other side, and here I go again, I'm going deep in the dermis first, or just in the sub-Q, and then I come up and I come a little bit more superficially, and that raises the wheel. And I would repeat the same thing from the other side. Okay, and this way I've anesthetized that whole area, but I've really hopefully only caused the patient the 2 sticks after my tuberculin needle. Okay, so back to our IND. So we've given our local, we've prepped with some betadine. And you're going with your knife, and you're going to have a sawing motion, okay? So you're going in, let's try over here. You're going in, and then you just saw using your number 11 blade, And you can see that you can really control that. And you can imagine that this might be better in a situation where you're going into a cavity or an area that has a bunch of fluid in it. I hope that you can appreciate that it might give you better control to use the number 11 blade. And you saw up. Your cutting action is really kind of happening as you're moving the knife upward. Okay? Here. Okay. Having trouble scrolling up to see your questions here. Okay.
I can always read them as well, but I don't see any in the queue at the moment. So if anyone has any, then go ahead and send them, and then I can read them for you.
Thank you. Okay. So let's do an excision of the lesion, and then we'll do some laceration or some suturing kind of stuff, okay? So here we go. I put my little fake lesion here. This pig has a problem with a blue spot. And so first thing I'm going to do, if this is something that I think is more suspicious, like I think it's a basal cell or something, then I'm planning for about a 5 mm margin, which I'm going to estimate. Ordinarily, I would do this with I would actually go ahead and take a ruler and dot out 5 mm all around. So actually, I can do that with this. So I would do this, 5 mm. Now, if this is a benign lesion, you're just basically going to go right around the lesion and take it out, okay? So I'm going to go ahead and complete that line. Okay, this is about approximately my margin. I'm slightly off on one of these sides. Okay, so now I'm going to design my excision. A little tougher to see the relaxed skin tension lines in this pig. So I'm going to go with the direction where I think that there's more tissue redundancy, which is this way, as opposed to this way, okay? So here I am, and I do this so often that this is really based on a gestalt, and I'm sure that for most of you it's probably the same. I mean, you're not going then literally measuring like 3 by 1, but you're kind of looking and seeing, about what kind of a lenticular excision am I going to design that is going to allow it to close without a dog ear. We'll see how close I came to that estimate. And that's a general estimate. It's usually 3 to 1. It doesn't mean that it's, it has to be precisely that. So 1. Yeah, I'm at about 3.2. Okay. So now I'm taking my 15 blade. And like I told you, instead of going like this, angling in, I typically am angling slightly more out. At the edges, if you want to be very precise, cut away from the edge, okay? That way you won't overshoot. All right, I'm coming the other way. Again, I'm going to angle out slightly. When I come to the end, I'm again going to, I might need a forceps at this point. But I'm going to angle away. All right, here we go. And now we're going to take this lesion off. Obviously, if it's something concerning, you're going to mark which end is which. Okay. All right. So hopefully we're doing okay and everybody can see this all right. Okay, so let's go ahead and close this. Again, so since this is an extremity, I would probably be using a 3/0 nylon would be what I would typically be using. Right now, I am using a silk suture, and that's only because I want you to be able to see a little bit more
Question,
clearly.
Dr. Pozo. Someone wants to know, how do you mark the end?
How do I mark the end of the lesion? I don't know if I understand the question.
I'm not sure. We'll wait for...
Okay. All right. So a couple of different approaches. If you are pretty sure that the ends of the incision are going to come together fairly easily, which this one is, I typically will just go in the middle and then just sort of space out my sutures after that. If I think that there's a lot of tension in the middle, then I'll actually start on the outside. And if you can imagine, you're offloading the tension as you come more towards the center of the excision, and it usually will close more easily that way. Okay, this looks like it's going to come together pretty easily. Okay, so I'm just going to go right in the middle. So, and I'm just going to close this superficially, and then we will do some more laceration repair and talk about deep dermal stitches. Okay, so this is just a simple interrupted stitch. So I'm going through the skin. Now, what my assisting hand is doing is actually more important than what my operating hand is doing. So I'm really everting this tissue so I can see it. I'm turning my wrist. I'm coming through the other side, everting again. You know, I am probably more aggressive with these tissues than you typically might think, because you really want to show this to yourself so you can see well, okay? So here we go. All right, now in an instrument tie, you're going to wrap around once. Now I typically usually only wrap around once. A lot of people when they're starting out will wrap around twice, which is a surgeon's knot. And that's okay to do because it usually will hold things a little bit better for you so that they stay better approximated. And you want to turn such that it lies completely flatly, which makes it square. If you see that it's a little twisted like this, you know that you're not square. But if you go the other way, you'll see that you're lying square. And here I am, again, putting my next knot down, and again. Okay, the way that I know that I'm square is that I always try to make sure that the instrument is closer to my area of operation. So if you can imagine, this is where the laceration is. If I keep my instrument, my needle driver, on this side of the suture, I am closer to this laceration than if I am on the outside of this suture. If I stay on the inside, and here again, I'm on the inside, okay, in here, which is closer than out here. If I stay on the inside like that all the time, I have a square knot, okay? In most of the things that you're going to be closing, quite frankly, it really doesn't matter. It's nice and elegant and good form to have a square knot, but you're not sewing on the aorta here. So, you know, it is not a key hemostatic stitch, so it doesn't really matter all that much. Now I'm going to show you a horizontal mattress, okay? Now this was the stitch that I talked about earlier that is good for when you are doing a palmar laceration and will give you good eversion and And I think somebody asked me about that. So here I come. I'm coming in on one side. I'm coming out on the opposite side. Okay, and now if you reposition your body, you can just go forehand. I'm going backhand right now. It really does not matter. But what you want to do is basically make a box. So the same amount of distance from the wound edge, I'm going back into the skin. And then again, I'm going to come back through on the other side, again, approximately the same distance from the wound edge. So you're creating a box. Okay, so we went in here, came out over on the other side, went back in about the same distance from the wound edge, and then came back out on the other side, okay? Here we are tying, and if you can see, this automatically raises, got a little dog ear here, but this automatically raises that tissue. Do you see that difference between this and this? This is automatically going to give you eversion. Great for using in the hand. You want to be careful though, because a horizontal mattress is a slightly ischemic stitch. So you don't want to get too crazy using horizontal mattresses everywhere, because it is an ischemic stitch, okay? But I hope you can appreciate that that is giving me a wound edge that is more raised than the other, than the simple interrupted, okay? All right. So now let's look at doing a deep dermal stitch before you do your superficial simple interrupted. So here we are.
We have a few questions.
Now deep, yes, let's
So
do some
clarity
questions.
with that other question was, Laura said that you said something about making the ends if the lesion was suspicious. So I think it may have been the comment that you made about doing the removing the suspicious lesion.
Yes, so okay, if you know that something is definitely benign, I would just make a circle just right around the lesion itself, or at most take out 1 millimeter. That way you're going to avoid taking out too much skin, okay? So something that's benign, you know, I'm just coming around like right around this thing. And then I'm going to design my excision, as opposed to specifically entities like basal cell carcinoma or squamous cell carcinoma. At the very least, you need a 5 millimeter margin. So then in that case, I would use some kind of ruling device and mark out, you know, 5 millimeters from the edge of that lesion, which, as you can imagine, makes for a much larger excision, you know? So in that case, I'm starting with this. And I have to now redesign an excision based on that larger circumference. Does this help that question at all?
We'll wait for her to respond.
We'll see. Hopefully she'll
Then we
respond.
have another question. Are there any tips on what to do if you have a second, if you have to do a second incision if you did not get a good margin?
Second incision when you didn't get a good margin. I would basically go around, you're going to have to excise that scar, okay? And what I would do is here's my pen. Here is my marker. Okay. So now you have a scar. that where the pathologist says that there's been a problem. So we're here. Of course, you're going to see at which margin they said you had the problem. So if you know that it's, you know, your superior or inferior margin, or your, you know, left or right side, you can then design your scar excision a little bit more precisely based upon that. And of course, if it's a deep margin, then you're just going to have to go deeper than you did last time. But most of the time, and for the types of things that you're probably going to be removing, it's just a matter of getting a few millimeters more. And I would just plan it around my scar. So I would say, okay, well, fine. Let's take another, you know, we'll go 5 millimeters again. And I would do that along the length of the scar. I hope you get a general sense. I'd go along the length of the scar. And of course, now on your second excision, you are going to have, again, a slightly longer. It's going to be slightly longer than your first one. But I would take, you know, an additional margin around the scar, depending on what the pathologist is telling you what's the closest. But you're typically going to be taking out the full length of that scar, and it's going to be slightly longer, not as long as the 3-to-1 ratio, because as you see, I'm going to make an excision that's something that's much closer to a linear excision than it is a lenticular one like this. So it's not going to be as long as that 3-to-1 ratio that I told you last time.
Thank you. I think that helped. Then we have one question about dog ears. Any suggestions on how to fix dog ears? And then we and then we probably only have time for one more demonstration because it's 9:25.
Perfect. We'll just do, after this, I'll just do the deep dermal stitch. And I think that's really all you're going to need, because I've already showed you the simple cutaneous stitches. Okay. So here I have this dog ear. I'm trying to show you the best angle. You know, obviously, well, yes, I everted it here, which is making my dog ear even worse. But these two edges don't fall together perfectly. So what you can do is take your scissor. Usually using a scissor will probably work for most of us best. And open kind of along what would be one side of your excision. So here I am, I'm cutting. And eventually I'm going to get to a point where it seems as though this is now going to lie flat. I'm going to keep going until I kind of take that excess skin, that dog ear at the end, out. So I'm just cutting straight along one line, and now I feel like, okay, this is lying pretty flat. And if you put that down, you'll notice that it's a triangular piece of tissue. It's a triangle. Okay? So now I am going to cut that triangle out. And now the dog ear is fixed. I think that's the best way to fix a dog ear. Okay? And then let me just show you how to do a deep dermal, and then I think we're all set. So deep dermal suture, you're going to be using, you know, I recommended to you a monochrome suture, which is tough. This is kind of a clear looking suture. I don't think you can see this. So you should be using the monochrome. I am going to switch to a silk so you can see. Okay. So all you have to remember is the mantra: deep to superficial, superficial to deep. Deep to superficial, superficial to deep. Okay? So you're typically going to start on the side of the laceration that is closest to you, because that's just what works well ergonomically. Okay? So closest to me, I'm starting deep to superficial, and you're coming up, you're starting at a point that's deep in the dermis to a part that's slightly more superficial in the dermis. Okay? So here you are. And then you're going to go on the other side at the same level. So again, I'm everting my tissue so I can see, okay? And I'm going at about the same level, superficial to deep. This needle is a little big for this size of needle driver I have. Okay, I'm going superficial to deep. Pulling through. And now we're going to tie, and this should end up with a knot that is deep. Okay, because you started deep and you ended deep. Deep to superficial, superficial to deep. Okay, that's your deep dermal stitch, and you're going to follow that with a superficial, simple interrupted stitch over top of that for repairing a laceration. Okay. Any more questions, Sabrina?
So far. Wait, here comes one. Spoke too soon. Okay, I'll just send it out to you. This one says, Philip says he has several questions and would love to be able to, I lost it, would love to be able to submit questions at a later date through email, if that's possible.
No problem. No problem. And then it seems like Dr. Esplin has a question about number of knots. For any monofilament suture, you should probably use something like 4 knots. It's probably a good moniker. I find that's enough. People try to make it a little bit more complicated, and they say, okay, depending on the size of the stitch, is the number of throws that you should use. But I think that typically if you're putting in about 4 knots, you should be okay. And that'll be fine for using the monochrome in the deep sutures. You can do 3 or 4 knots. And on the skin, typically I'm doing about 4 knots for any of the sutures that I told you about using. And you'll see, I mean, if you're using a very, very large, like 2-0 proline, and if you're seeing your knots kind of unraveling, then you can, you know, throw a couple more in. And sorry, I didn't have enough time to show you